Okay, so before we talk about the management and diagnosis of TIA, I feel that it's important to cover the burden of stroke. So 1 in 6 Australians will have a stroke in their lifetime. It's the number 2 cause of death worldwide, the number 1 cause of disability in adults, and about 2/3 of stroke survivors will be left with a permanent disability which requires some assistance with day-to-day activities. This is important because the TIA is basically the last chance to prevent a future stroke. A patient who's had a TIA has a 10% risk of major stroke within the first 10 days, a 25% risk of a systemic vascular event within 3 months, most of which occurs within the first 48 hours. The important thing is that up to 80% of that risk is preventable with urgent assessment and institution of risk factor management. So before I go into all that, I'll go through the definitions of TIA because they've changed recently. In the past, there was a time-based definition. So a TIA previously was defined as an acute neurological event thought to be of vascular origin lasting less than 24 hours in duration. But in fact, studies showed that more than 50% of these patients actually did have established infarction on MRI. So the new definition is a more tissue-based, so a sudden onset, focal, transient neurological deficit, caused by ischemia in the brain, spinal cord, or retina without any lasting infarction. So you can have brief episodes of neurological deficit that can last less than 24 hours, but you do end up with brain injury, and that's now defined as a stroke and not a TIA. So for example, this was a 68-year-old man who presented to ED with 2 episodes of what sounded like expressive dysphagia, lasting less than 5 minutes each. By the time we saw him, he was neurologically normal. His CT head on the left looked normal, but the MRI on the right, this is a DWI sequence, showed that there are 2 small areas of diffusion restriction within the left frontal lobe, sort of the Broca's area, which essentially defines this as a stroke and not a TIA. So how do you approach these patients who you suspect are having a TIA? The history is very important. A TIA would be of abrupt onset, with the deficits being maximal at onset and focal, so you can localize it to a single vascular territory within the nervous system. On neurological examination, if they're still having ongoing deficits while you're examining them, then you need to refer them to the hyperacute stroke pathway and consider them for reperfusion, so either thrombolysis or thrombectomy if it's relevant. And then the last aspect is to consider whether it could be a TIA or a stroke mimic, which can make up to as high as 60% of patients who were initially thought of having a TIA. So this was a study of 512 patients who were referred to a TIA clinic by GPs, and it showed that only 38 patients were eventually diagnosed to have a TIA, and more than 60% actually had mimics. This was in the UK, but our findings here are quite similar. So the common mimics we see are migraine with aura, syncope of either cause, vestibular neuronitis, epilepsy, TGA, and another one that isn't actually mentioned here is conversion disorder or somatization that we see quite commonly as well. So that's important to keep in mind. So just some points on the history which might help to differentiate some of these mimics from TIA. One of the most common ones is migraine with aura. So an important feature is the temporal profile. So the migraine aura will be quite gradual in onset and progress in severity or spread over a period of minutes, quite typically. And in a similar way, it will resolve over a period of minutes, as opposed to TIA, which will be abrupt in onset. The symptoms will tend to be quite positive. So in a TIA or a stroke, you get negative symptoms such as loss of sensation or loss of vision, whereas in a migraine, the symptoms tend to be things like paresthesia, pins and needles, or visual scotomas, so positive symptoms. So for example, on the right here, this was a scintillating scotoma which was drawn by a patient. It started off with this small zigzag image initially, and then over a period of 20 minutes or so, it progressed into this here. The patients will often have a personal or family history of migraine. It may or may not be accompanied by a typical headache, which tends to be unilateral throbbing associated with nausea or vomiting, photophobia or phonophobia. But you can actually get a migraine aura without a headache, so an acaphalgic migraine, which can sometimes be tricky. The other differential, the other mimic, is a focal seizure. Now, this can be a little more tricky to differentiate from a TIA because the onset can also be quite abrupt or over a period of a few seconds or minutes. Again, a focal seizure will be associated with positive phenomena as opposed to negative, and a preceding psychic aura, such as a feeling of impending doom or deja vu, or even a sensory aura, is quite common. It's important to get a witness history because there may be some unconscious automatisms that the patient might not be aware of, such as chewing or lip smacking or jerking movements. The symptoms can spread beyond the vascular territory, and consciousness may or may not be impaired. The third one is TGA. Again, the witness history is quite critical for the diagnosis of this. It can start quite suddenly, last a few hours, and then resolve quite suddenly, leaving a dense amnesia gap. The key on history is repetitive questioning, and it's characterized by both retrograde and anterograde amnesia, and the patient may or may not have a headache afterwards. TGA tends not to recur again, but the patient may have another episode down the track, but it is uncommon. So if that happens, then you need to consider other diagnoses such as transient epileptic amnesia, which is something that needs to be treated. I won't go through this in too much detail. These slides will be available later, but it just goes through all the TIA mimics and some of the demographic and history features that can be helpful to differentiate. So once you've diagnosed a TIA, what do you do next? You need to consider the etiology and therefore secondary prevention. So as a general rule, about 25% are due to a large artery disease, 25% are due to small vessel disease, 25% are cryptogenic, so where we don't know what the etiology is. About 20% are thought to be cardioembolic, and the rest are due to other causes, so thrombophilic state, vasculitis, dissection, arteritis, and things like that. So if you've ruled out all the major causes, then you need to start thinking about some of the more uncommon causes of TIA or stroke. So what are the investigations you would need to do if a patient like this presented to you? You would do an ECG immediately. We would do a CT non-contrast to rule out a bleed mainly and other pathology, and we're tending to move towards doing a CT angiogram of the head and neck vessels as opposed to a carotid ultrasound, which we used to do in the past. The reason for this is that a CTA is easily available at any center that can do a CT. It also examines the entire length of the carotid artery, whereas the carotid ultrasound only looks at the short segment of the cervical carotid. And thirdly, the CTA also assesses the posterior circulation, which we can't assess using ultrasound at this stage. So if you can do a CTA, do it straight away. Obviously, there are patients in whom contrast is contraindicated for various reasons, and for those patients, you would refer them for an ultrasound or an MRA down the track if required. It's important to try and get the CT at least done within the first 24 hours, and any vascular imaging done within the first 48 hours. We would do fasting lipids and glucose. An MRI is not necessary in everyone. It's more just for diagnostic confirmation. So if you're unsure of what the diagnosis could be, you could do that. Or if it was unavailable or the patient had a contraindication, such as a pacemaker, you can do an interval CT scan within sort of four to 5 days of the initial one to confirm that there has been a stroke. The transthoracic echocardiogram and 24-hour Holter you can arrange within the first 2 weeks, and basically you're looking for cardioembolic causes of stroke. So AF, an akinetic left ventricular segment, endocarditis. If they have a PFO, if that's what you're suspecting, then you would also request a bubble study with the transthoracic echocardiogram, particularly in patients who are age younger than 60 and have no other vascular risk factors to explain the TIA or the stroke. If all of that comes back normal, then, as I mentioned earlier, you would consider additional workup, so thrombophilia and a vasculitis screen, a transesophageal echocardiogram or prolonged cardiac monitoring, and other genetic causes that might be responsible. So once you've diagnosed a stroke, a TIA, and you've done the initial investigation, how do you stratify the urgency with which they need to be managed? Do you admit them or not? I know the ABCD2 score had been quite popular, but it's gone out of favor more recently because it's been shown to be quite poor in predicting distinguishing between low and high risk TIAs, as well as between TIA and TIA mimics. So we tend to now use the ABCD2 plus I score, where I is the presence or absence of infarction on the DWI MRI sequence. The ABCD2 basically are age over 60, high blood pressure over 140 on 80, whether they have unilateral weakness, whether there's speech impairment, whether the duration of the deficit lasted more than 60 minutes, and the presence of diabetes. These are all high-risk indicators of recurrent stroke within the next 2 weeks, basically. Another one is crescendo TIA, and if someone's having a crescendo TIA, then we would recommend admitting them to hospital, getting the vascular imaging done, etc. So basically the definition is more than 2 events per week, increasing in frequency and duration, and basically this is an indicator that there is a high risk of impending stroke. So you try and get the carotid imaging or the posterior circulation imaging done within the first 24 hours, refer them for vascularization if it's relevant as soon as possible, start all the secondary prevention medications straight away, do all the cardiac investigations as an inpatient, just to try and reduce that risk as much as possible. In patients otherwise, you don't necessarily need to admit them to hospital as long as you can get the CTA within 24 and 48 hours respectively, and the cardiac investigations within 2 weeks. But essentially, starting early secondary prevention is important because it reduces the risk of a disabling stroke by 80%, as I mentioned towards the start of the talk. So as soon as you get the non-con CT head, which confirms that there is no bleed, we would start them on an antiplatelet and a high-dose statin. And you need to do this before the patient leaves your site. So the evidence for antiplatelets is actually equivalent for aspirin, clopidogrel, and dipyridamole. We tend to use aspirin because that's what we have available as a first line on the PBS, unless they have hypersensitivity or they failed aspirin, then you would go to clopidogrel. But otherwise, as a first line, we tend to use aspirin. For a high-dose statin, that means something like atorvastatin 80 milligrams or rosuvastatin 40 milligrams, and that's been shown to reduce mortality as well as secondary cardiovascular risk. You would start an antihypertensive. You typically wouldn't do this until you've confirmed that there is no high-grade carotid stenosis. But once you've got that, you would start an antihypertensive, aiming to keep the blood pressure below 140 over 80 over the long term. If they do have a carotid stenosis, then you need to try and consider revascularization as early as possible. And I'll go through that in a bit more detail down the track. If there's atrial fibrillation and it's just a TIA, then anticoagulation can actually be commenced at day 1. You don't need to wait as you would with a stroke. And lifestyle modification, including diet, smoking cessation, and physical exercise is just as important. So I'll talk about carotid stenosis, which is responsible for 10% of all stroke, but it's actually a major cause of recurrences. The evidence for revascularization is highest within the first 2 weeks of the ischemic event. However, you shouldn't wait for that long. In patients who are stable, such as those who have had a TIA, you should try and get the surgery done as soon as possible. And patients can be kept on aspirin throughout the preoperative and the perioperative period. So obviously, if the patient's had a major stroke and the hemiplegic, etc., the surgery might need to be delayed for 4 weeks or even longer. But in stable patients, you need to try and get it done ASAP. And those who are having crescendo TIAs or TIAs lasting longer than 60 minutes or so, you should admit them straight away to get this done as early as possible. The strongest evidence is for patients who have carotid stenosis between 70 to 99%. That is symptomatic, so if they've had a stroke or TIA on that side. And these patients should have a carotid endarterectomy within 14 days, as I said, and that's a grade 1 recommendation. For patients who have a stenosis of 50 to 70%, or a high-grade stenosis, a carotid occlusion, or just a trickle of flow, the evidence is basically not there. So you can either consider medical management for 50 to 70% stenosis. For carotid occlusion, we generally wouldn't refer them for surgery at all. For asymptomatic carotid stenosis at this stage, surgery is not recommended, and we would just recommend optimal medical therapy, so an antiplatelet, statin, antihypertensive, lifestyle modifications, etc. At this stage, carotid stenting is still an unproven procedure in most patients. So the CREST trial showed that the risk of stroke or death was higher with carotid artery stenting than with endarterectomy. However, a subgroup analysis showed that there might be a possible role in patients aged below 70 who actually did better with stenting rather than carotid endarterectomy. There are also some other patients who may be unsuitable for surgery, such as those who have a higher risk of anesthetic, unfavorable anatomy or who have had previous radiation therapy and resulting fibrosis, who you might consider stenting for. But for the most part, for the time being, carotid endarterectomy is recommended over stenting. The CREST-2 trial is ongoing, which is looking at this in further detail, but the results are not available yet. So I'll talk about atrial fibrillation. Anticoagulation is, for the most part, underutilized. So if someone has atrial fibrillation, you need to, and they just had a TIA, which means that there is no established infarction on MRI, you should start anticoagulation day one. So which agent would you choose? So firstly, you would determine whether they have valvular or non-valvular AF. The definition of valvular AF is a mechanical valve or moderate to severe mitral stenosis, and those patients require warfarin. For anything else, so aortic stenosis or a bioprosthetic valve, you can actually go and choose a NOAC. Other indications for warfarin, so if their creatinine clearance is less than 25 mils per minute, if they have an LV thrombus or an akinetic left ventricle, if they have underlying malignancy which is causing a prothrombotic state, if they've been on warfarin long term and have had stable INRs, I would leave them on it. And the other ones are the possibility of drug interactions. So if they're on phenytoin, carbamazepine, some of the azole, antifungals, etc. So for those patients, you might consider warfarin. Otherwise, you would select a NOAC, and you can select one based on the patient's characteristics. So I'll just go through. This is just a summary of the three NOACs that are available in Australia at the moment and the characteristics of them. I'm sure you're all very familiar with this. So dabigatran is the direct thrombin inhibitor. The major features are that it's 80% is cleared renally, so it's basically contraindicated in anyone who has renal impairment. Rivaroxaban and apixaban have various degrees of renal clearance and can be used in these patients, although you might require dose adjustment. Dabigatran has a reversal agent, idarucizumab, and it can also be hemodialyzed. Rivaroxaban and apixaban have a reversal agent in phase 3 trials, which should be available soon. In terms of the efficacy, they were all shown to be either equivalent or superior to warfarin. So basically, dabigatran 150 milligrams twice a day. Rivaroxaban and apixaban were all superior to warfarin, and dabigatran 110 milligrams twice a day was essentially non-inferior. In terms of safety profile and risk of major bleeding, apixaban was far superior to warfarin in the Aristotle trial. Rivaroxaban and dabigatran 150 milligrams were non-inferior to warfarin as well. In terms of GI bleeding, rivaroxaban was actually worse than warfarin. However, the overall rate of major bleeding was non-inferior. Apixaban and dabigatran 110 milligrams BD were superior to warfarin in terms of risk of GI bleeding. And in terms of the risk of intracranial hemorrhage, basically all of the agents were superior to warfarin in terms of the overall risk. I think those are the major features of all of the NOACs. So how do you use that information to actually select one for your patient? So if someone is having recurrent ischemic events, for example, if you have a young patient who has a very low bleeding risk, and your major concern is to prevent further ischemic events, then you would probably go for dabigatran high dose, so 150 milligrams BD, which was shown to be superior to warfarin in preventing systemic ischemic events. If someone has moderate to severe renal impairment, then you could either use warfarin, rivaroxaban, or low-dose apixaban. If there's a high risk of bleeding, so it has blood score of more than 3, then you could consider apixaban, which had the best safety profile out of all of them, or low-dose dabigatran. If there's a high risk of GI bleeding, then apixaban or low-dose dabigatran are better than rivaroxaban and warfarin. If you're worried about compliance, then rivaroxaban is better because it has a once daily dosing, or warfarin where you can measure their compliance by way of the INR. And just keeping in mind that apixaban would have a dose reduction in patients who are age above 80, weight less than 60, or a serum creatinine more than 133. So I'll talk about hypertension next. Hypertension is thought to be the single most important modifiable risk factor for stroke because it promotes the formation of atherosclerotic plaques. Antihypertensives should be deferred for the first sort of 48 to 72 hours after an ischemic stroke, and the reason for that is that the higher blood pressure is thought to be important for maintaining cerebral perfusion in that initial hyperacute period. Or longer if the patient has a large vessel occlusion, as we've already discussed. And then once they've had revascularization, you need to restart their antihypertensive therapy. So long-term blood pressure management should be at an aim to keep it below 140/90. First-line agents that have been established in stroke are ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, or thiazide diuretics. Beta blockers are not established as first-line agents unless they have another indication, such as ischemic heart disease, etc. I thought I'd talk about alcohol because there was a study published in The Lancet in June of last year, which was quite significant. The current recommendations for alcohol are less than 2 standard drinks per day for men and 1 standard drink per day in women. However, this study showed that more than 100 grams of alcohol per week, which is equivalent to around 5 to 6 standard drinks, is actually the threshold, and beyond that there is a higher risk of stroke. So they followed nearly 600,000 patients for a total of 5.4 million patient years, and the main finding with 100 grams per week was the threshold, not just for stroke or vascular risk, but all-cause mortality. So actually that may be the new safe limit. However, I don't see the guidelines changing anytime soon. Similarly for cigarettes, there was actually a study which looked at the risk of smoking 1 cigarette per day and found that the risk of stroke and cardiovascular disease was half of that of people smoking 20 cigarettes per day. And basically the bottom line was that there was no safe level of smoking for cardiovascular disease, and any patient who smokes should be advised to try and quit altogether rather than cutting down significantly. Diet and exercise, I won't really go through that, just highlighting that Mediterranean diet has been established in preventing cardiovascular disease as well as mortality in people who already have established cardiovascular risk factors. And regular aerobic physical exercise and weight control is important in indirectly reducing stroke risk by improving other factors like hypertension, blood sugar control, serum lipid levels, etc. I thought I'd talk about driving quickly because I've been asked about that. If someone's had a TIA, so if there is no established infarction MRI, a patient is not allowed to drive for 2 weeks for private vehicles or 4 weeks for commercial vehicles. If they've had a stroke, then for private vehicles, they're not allowed to drive for a minimum of 4 weeks. And for commercial vehicles, it's a minimum of 3 months. And after that, they actually require a doctor's clearance. That can be the primary care provider. So how do you clear them back for driving? If the patient has ongoing neurological deficits and you're concerned about their ability to manage on the road, then you can actually refer them for an on-road driving assessment. For visual field deficits, the patient will actually need a formal ophthalmology assessment and a formal visual field testing. So basically, normally you have a horizontal visual field of somewhere between 160 to 200 degrees with both eyes, and that's important for the perception of vehicles on the side or other hazards in your peripheral vision. To be able to drive again, you need at least 110 degrees of total horizontal vision, which a formal ophthalmology review can provide. They would also assess the vertical visual fields as well as the central visual fields, and there are cutoffs for that, which I won't go into because they're quite complicated. So those are the things that you need to keep in mind before clearing someone to go back to driving after a stroke. So the take-home messages, basically TIA is a high-risk presentation and you require urgent assessment and treatment, including ECG, carotid imaging, antiplatelet, high-dose statins, and an antihypertensive. And the available evidence suggests that implementing this within the first 24 to 48 hours reduces the relative risk of stroke, major vascular events, and mortality by 80%. Before I open up for questions, I thought I would just show this. This is just a website, magicapp.org, which covers all the most up-to-date guidelines for TIA, for stroke, for hemorrhagic stroke, etc. It goes through everything in detail, and I think it's quite a useful resource if you're unsure. It goes through all the antiplatelets, the carotid guidelines, anticoagulation, etc. It also has stroke case studies that you can use. It goes through CT interpretation for, these patients coming through the emergency, and I think it would be relevant for doctors and all other multidisciplinary members looking after stroke patients. So I'll just stop there and see if there are any questions.
All participants are now unmuted.
I think if you search Magic App. Just a question from Kununurra.
Sure.
So you said that only 50% of patients who were previously diagnosed with the TIA ended up having some evidence of stroke on MRI. But if we're using CT to sort of exclude any stroke, and then assuming they have no signs on CT that they've had a TIA, and then starting a NOAC within 48 hours, what about those patients who on an MRI would have had signs that they've had a stroke? Is there any risk to them?
Yeah, look, that's a great question, and this is obviously a major problem in centres, particularly in WA, where there is no MRI available, or even in patients who have a pacemaker or another contraindication to MRI. Basically, we accept that there will be a small proportion of these patients who may have a small stroke on MRI that we're missing if we're just doing a CT scan. However, if the stroke is that small, that we're not seeing it on CT scan, then we would assume that the risk of hemorrhagic transformation from starting anticoagulation is probably negligible. So say, for example, someone has had a stroke on an MRI and they have atrial fibrillation. How do we decide when to start anticoagulation? That depends on the size of the stroke as well. So if they have a small stroke, then we might wait 1 or 2 days. If it's a moderate stroke, then you might wait 3 to 5 days. And if it's a large stroke, then we would wait 2 weeks or even longer. But if the CT, so basically you can do a CT initially. If you don't have an MRI available, repeat the CT the next day or in a couple of days. And if you still can't see an established infarct, then it's safe to say then you can probably start anticoagulation at that stage.
Sure, thank you. I just had one more question.
Sure.
Just about the timing for the carotid endarterectomy. In practice, can that happen in 2 weeks in the public system? So if we're referring patients down, is there like a streamlined pathway that we should use, or we just refer them to vascular outpatients as we usually would?
No, I wouldn't wait for outpatients. If you have a patient, say in Kununurra, who has had a TIA or a stroke and has more than 70% carotid stenosis on that side, then I would talk to neurology, in your tertiary centre to try and get them transferred as an inpatient, because it does make a difference to outcomes. We generally wouldn't wait for outpatient vascular review because that could delay things unnecessarily.
Sure.
Hello, Stuti, can you hear me?
Yes.
Thank you for a great presentation. My name is Werner. I'm a consultant emergency physician. The topic and what you've covered has always been a challenge for a number of reasons. So 2 questions. One, how can we access your presentation if we have an opportunity in future to share it with our colleagues? That's the first question. And the second question is in relation to posterior circulation and ways people may present and the clinical conundrum being the patient who presents and you're forever asking yourself, is this a peripheral or central cause for their, let's say, vertigo? In your clinical practice, have you found any useful ways of deciding it's one or the other so as to support your after-hours decision-making when you don't always have imaging available?
Sure. So just to cover your first, just the first question. I've done a number of these talks now, and quite a few of them have been recorded, and they should be available online via the Tracks WA website. But I'll ask my colleague Karen Gifford to share that around, and this one will be available as well. All the PowerPoint slides will be available as well if anyone needs to refer to them down the track. For your second question regarding posterior circulation, TIAs or strokes, this is really difficult. Obviously, there are some clinical presentations that make it quite easy for us to suspect that this might be the case. So, for example, if they have a cranial nerve deficit, for example, diplopia accompanied with ptosis, an obvious strabismus or a skew deviation that wasn't there previously, facial palsy, some of the lower cranial nerve signs which cause bulbar following dysfunction, that can make it quite easy. Any obvious established cerebellar signs, can be helpful as well. But if they just have vertigo, then the history might be important, or the HINTS exam is what we use, and I think the physios use that as well. Obviously, it's not foolproof, but that can be quite useful as well. So the HINTS exam, the HINTS it stands for Head Impulse Test. So basically, what you would do is hold the patient's neck, ask them to focus their eyes on your nose, for example, and gently move it side to side, okay? And basically you're looking for the VOR, or the vestibular ocular reflex. So in a normal person, if you move the head to their, say to one direction, their eyes would compensate and move in the opposite direction to maintain fixation. However, if the HINTS test is abnormal, where they have catch-up saccades, so if you move the head to one side and their eyes seem to catch up in that direction, then that indicates a vestibular dysfunction on the abnormal side. So if you moved it to the right and they had catch-up saccades, then that indicates that there's right-sided vestibular dysfunction. And that can be reassuring to some extent that, perhaps this is the vestibulopathy. But at the same time, I have been caught out in that a patient's had a previous vestibular problem. These new symptoms are not related to that, but they have an abnormal head impulse test, because of that. But that's helpful. The other thing is nystagmus. For a peripheral nystagmus, it would follow Alexander's law. So basically, Alexander's law states that someone with a vestibular problem, the nystagmus would increase in amplitude and in velocity if they look away from the side of the lesion. So say if someone has hearing loss, fullness, or tinnitus on one side, and they have a purely horizontal nystagmus with maybe a torsional component, so a slight rotatory component, if that nystagmus increases in velocity and amplitude if they look away from the abnormal ear, then that all fits with a peripheral lesion. However, with a cerebellar lesion or a central lesion, Alexander's law also states that nystagmus would increase in velocity and amplitude towards the side of the lesion. So again, that can be helpful. So if it's a purely horizontal or with a slightly torsional component and unidirectional, then that supports a peripheral lesion. However, if it's direction changing, so for example, if you look to the left and it's left beating, but then you look to the right and it's right beating, then that's suspicious for a central cause. Up beating or down beating nystagmus is almost always central, and that's when you have to do CT angiogram. What's the last aspect of this the skew deviation? So a skew deviation is basically a vertical misalignment of the eyes. So you can just ask them to look at you, and in some patients it'll be quite obvious that the eyes are misaligned on a vertical plane. If it's not obvious, what you can do is get the patient to focus on your nose again, get them to keep looking at you, cover one eye, and you might see that the other eye adjusts itself, so it either moves in or moves up, and then you cover the other eye and the same thing happens on the other side. That eye moves in or out to maintain fixation on your nose as you've asked them to do, and that's another sign that they might have a subtle skew deviation that you're missing. But yeah, overall you can look up the HINTS test. There's quite a few articles online that you can refer back to. The third thing is if they have had a sudden loss of consciousness, or they're just drowsy without any lesion, sometimes that can happen from a posterior circulation stroke or a top of the basilar lesion that can be associated with problems with vertical gaze. So if someone's just suddenly drowsy, then that's quite suspicious, and you would want to scan the basilar arteries, basically. Does that make sense?
It's fantastic, Susie. Really appreciate your response. Thank you.
No problem. Any other questions or? If there's no other questions, I might stop there. If anyone wants a copy of the presentation, please feel free to email me via global mail or my colleague Karen Gifford, and we'll be able to pass on the details. But it's study.joshi@health.wa.gov.au.
Thanks so much, Judy. That was excellent.
Thank you.
No problem. Thank you so much.